This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you very much, Ben, for your kind introduction. To follow on the same theme, a wise and revered Scottish shaman once said that if you do have to present on something a bit dry and sparse, get your lecture in first before the punters fall asleep. So I'm delighted to be here, and I'm particularly delighted to be first up. Straight first cab off the rank is looking at evidence such as it is around rapid response teams and how effective they are in the paediatric setting. And actually, this is, I didn't find this very straightforward when I was thinking it through. And I guess the first problem is in the title. While the title is about rapid response teams, in fact, nobody has rapid response teams in isolations, and in fact they exist within a wider rapid response system framework. And I don't think we can separate how teams function from how the system functions as a whole, certainly not on the evidence that's currently available. The second thing that's interesting is from what evidence is around, the characteristics of the systems they're studying and describing are very different between studies, and even worse, how they then choose to report their data is very variable, and it makes it hard to compare studies. And of course, the majority of work out there comes from single centres. So just to move on, I suspect this article has been discussed already at this conference. It's a good place to start because it's a systematic review and meta-analysis of studies, which includes 5 paediatric studies and 12 adult studies. Looking just at the paediatric data that they discuss, when they pulled their analysis and looked at cardiopulmonary arrests, what they found across the studies was that there was a significant decrease in cardiopulmonary arrest following implementation of rapid response systems. However, when they looked at in-hospital mortality, the data there was more equivocal. 2 of the studies showed a significant decrease in in-hospital mortality, and the other 2 showed no significant difference. So we might just pick a few of the papers within this study just to look at in a bit more detail, just to identify some of the issues I've already mentioned. So taking Sharek's paper from 2007, it's a US paper, and they looked at essentially before, all the studies are before and after. They identified historic controls, they implemented a system, and then they studied going forward prospectively how their patients got on. So prior to implementation of their rapid response team, they had 55 months of data. It was 22,000 admissions, and the Americans seem to like talking in hospital days rather than necessarily admissions, so it was over 100,000 hospital days in that cohort. They then implemented a system and looked after implementation, and they followed up for 19 months, and there were just over 7,000 admissions and 34,000 hospital days. Looking at their team composition, it was a mixed team with intensive care physicians, RNs, respiratory therapists, and also a nurse supervisor, shift coordinator as part of the team. They studied, their endpoints were hospital-wide mortality and their code blue rates. And what they found was a significant drop in both hospital-wide mortality and the rates of their code blues occurring outside of the paediatric intensive care unit. And they estimated, based on their numbers, that in the 19 months that they studied this group, they perhaps saved as many as 33 lives. So, a positive study. That's good. We like positive studies. In fact, we positively favour and report positive studies. I'm glad Sharon's going to be up talking next because this paper is one of hers, and this was the Australian data which really led the way in reporting around this topic. Again, it was, if you like, following a prospective cohort and comparing it to historic controls. There was 41 months of data prior to implementation of a medical emergency team, and this number is hospital admissions, it's not hospital days. So this is a bigger study than the previous study. And again, after implementation, they followed. This is the follow-up paper of Jim and Sharon's, and they followed up for 48 months, and again, a substantial number of hospital admissions. Again, the team was a mixed physician-nurse team, drawing both from the paediatric intensive care, from the emergency department, and from the paediatric sort of home team. Again, looking at outcomes, the hospital-wide mortality dropped in this study, this second study in the series, significantly, and there was a decrease in preventable cardiac arrests and deaths. And again, estimating, look at the numbers, there was perhaps, again, 34 lives saved simply by changing the system. So another positive study. Richard Briley from 2007, again in the States. Again, it's a before and after study. It's quite a bit smaller than the previous study. So admission numbers 16,000 and 8,000 before and after. Again, and post 8,000 admissions, 52,000 hospital days. Again, it's a mixed team, so the teams are all looking surprisingly similar across the literature. Interestingly, and I've just flagged this up, as opposed to the other studies which tended to use physiological variables to trigger the team attendance, they went for illness descriptors rather than observations, so respiratory function getting worse, airway getting worse, suddenly completely unconscious, those sorts of things. And again, they looked at mortality and code rates. What they found was, and this study wasn't powered big enough to make a lot of statistically significant conclusions, but they found there was a decreased risk of respiratory or cardiorespiratory arrest, but they didn't find a significant difference in in-hospital mortality, and again they speculated their sample size may have been part of that. And I really loved Elizabeth Hunt's paper from 2008, also from the States. Again, it's before and after. Again, it's reasonably small in terms of, these are hospital discharges rather than hospital admissions. I don't know why they picked discharges, maybe lots of their admissions died. Reasonably small study, but I loved their team. They've got intensive care physicians, nurses, respiratory therapists, nurse shift coordinator. They also had a pharmacist to drop emergency medications. They had security there, so I think they're maybe a rougher part of town than Gold Coast. And they had a chaplain as well, which maybe explains why they look at hospital discharges rather than hospital admissions. So they had a very, very big team. They didn't give me any data on their MET dose, so I'm not sure if they found that they had a very high MET dose like many of us see, whether they still have all these people turning up to all the METs. But during the study, this was the team. Again, they went for illness categories rather than vital signs, and when they looked at their outcomes, significant decrease just in respiratory arrests, but not cardiorespiratory arrests. And I think that comes down to the activation criteria that they picked. It was mostly respiratory activation. Increased work of breathing, increased respiratory distress, retractions, falling saturations. So it may be that they've specifically favoured a group. Again, when they get to the discussion, they did wonder perhaps if they had used a physiological, heart rate above such and such, respiratory rate above such and such, blood pressure type activation criteria, whether it would have influenced the number of cardiopulmonary arrests they detected. Just moving away from the meta-analysis now, this study is from Ontario. It's a bit more recent, and so it's new data compared to the meta-analysis, but it compares 4 different level 3 centres across Ontario. It's a reasonably small study in terms of numbers of months conducted, but moderate numbers of admissions, but it's a multi-centre study rather than a single institution. Again, they have a mixed team which has medical staff on board. They didn't find any change at all in their hospital mortality, and they didn't find any change in their hospital cardiopulmonary arrest rate either. Really, the best they got was that in patients who have been discharged from hospital who then are readmitted back, in patients who are discharged from PICU and then readmitted back to PICU, the mortality in that reasonably high-risk group significantly fell. But this is simply PICU discharge readmission group. Again, when they structured how they did business, it wasn't simply calling criteria to phone for a MET. They also followed up children who had been seen before by the MET until such times that the MET team and the home care team agreed that they could stop following the patients up. And they also followed up PICU discharge patients. So again, perhaps they're selecting out certain types of patients. They don't specifically comment on that, I wonder. So really pulling it all together, we have some big gaps in the evidence. All the studies that I could find looked pretty positive. It looked like we were doing good. It looked like this mad rush for everybody to have a rapid response system has the blessing of some data behind it. But we are very poor at standardizing how we report our data, and that makes it hard to compare studies. And again, at the present time, it's not possible to separate out your team composition and seniority and how it functions and how they train from the overall system. There may be things we can do round about, the team who has the chaplain and the pharmacist. It might be, given that MET dose for most people has climbed since systems were admitted, it may be that they don't need all these people on the team and that they could get perfectly adequate results, the same results, with less people. But it's impossible to know that because the data doesn't allow us to pull that out. Again, in the adult world, one of the big things that struck me way back years ago was just how often, following implementation of a team in an adult hospital, there was improvement around about end-of-life planning for certain types of patients, and often the central role that teams played in driving the end-of-life planning process. At the present time, if there is data in the paediatric world on whether MET teams and rapid response teams do that kind of work, it's not visible data at the present time. I looked, but I can't comment at the present time on the literature in the paediatric world whether we significantly influence driving end-of-life decisions. And of course, wouldn't it be lovely if we had a big giant multi-centre trial? We'd know so much more. So that's a bit of a gallop. I'm a notorious overrunner on time, but the paediatric literature, such as it is fairly slim. I think on the evidence that we have, developing these systems seems reasonable. It seems to have the backing of some evidence. We do have gaps, and in another 10 years' time, possibly, we'll know more than we do just now.